much. Okay, our next presenter is Dr. Martin Chasen. So you have a slideshow as well. There's a sailboat. Perfect. Our favorite sailboat.
Okay. So good afternoon to all of you. So I'm a clinician in the trenches, and I think a lot of what I'm going to say to you is going to answer a lot of those questions, because I'm going to show you that it's all practically possible and it delivers good results. I'll present myself as from South Africa. I came here in 2004 to McGill initially, then went to Ottawa, and I'm now in Brampton. I am a qualified internal medicine specialist, as well as a medical oncologist, and I also have a degree in palliative medicine. In South Africa, which has the reputation of having the most hospices in Africa, we indeed have a recognized university degree. I was of that first class that got it in 2004. So we do see that it changed a lot of government policy by having it formally recognized. I'm going to reference two documents. The first document is the Bill C-277, which clearly says that in order for a patient to have a proper and to really have a voluntary decision to participate in medical assisted aid in dying, he must be given the choice for palliative care. I think that has motivated me a lot to develop what we've done. And then I'm not sure if any of you know this, the 2015 Quality of Death Index. It's a report by the Economist Intelligence Unit, and I think this is enough motivation to say that Canada is at number 11 on the list. This is not good enough. Before I got to Canada, I did read that the Honourable Irwin Cotler in 2002, when he was Justice Minister, said that palliative care is a basic human right, and I think we should move forward on that one. So you may have heard that many definitions of palliative care being an approach that looks at patients and their families who have life-limiting disease. It's impeccable symptom management. It definitely involves psychosocial, spiritual, physical, and every other domain of a human being. It's holistic care. At the World Health definition, there is a little attachment which people don't know, and I'm going to specifically speak about three of these attachments. Firstly, that palliative care affirms life and regards dying as a normal process. It doesn't hasten, nor does it postpone death. It offers the full support system to help patients live as long as possible and as actively as possible, keeping people as comfortable as possible for as long as possible. It has a goal of enhancing quality of life, and once again, applicable in the early course of illness. This is not just about end-of-life care. We now know from many clinical trials in patients, the most topical one is in patients with metastatic lung cancer, those patients who were randomly assigned to receive palliative care and normal chemotherapy had less chemotherapy and lived longer. So, this is the model that we've put together initially in Ottawa and now in Brampton, and really what it looks at is the four pillars. This is a model where we start off with an inpatient palliative care service for those patients requiring specific specialist palliative care, terrible pain that's not controlled, extreme anxiety, existential issues that the patient needs to come into hospital to be treated in a palliative care unit. We as well have a consultative service in our hospital where patients are referred to us from the different wards: orthopedic, medical ward, geriatrics, internal medicine, and I'll show you that. So patients are seen and are treated in conjunction with their most responsible physician. We cannot see all the patients. There are more than enough patients. So our aim is to build capacity. And I'm surprised that nobody's speaking about building capacity at such a great level, but we have an enormous obligation to build capacity. Then what we've recently started is the ambulatory outpatient clinic, where patients that are seen and are able to come to the clinic are seen. And then, and I'm going to show you some results of this, we have a robust community service. We have patients as being seen in their home by a physician as well as a nurse. We work as a dyad. Around this center, this pillar, these 4 pillars, we are embedded within education, because without education, we will never be able to build capacity. So in our specific area, in the LIN, we have made it a goal for us to have as many of the LEAP courses, the Learning Early Palliative Care. I'm sure you've heard of that with the Pallium project. So we are trying to do as many as we can to build capacity. And then, of course, we all need to know that research is important. Why is it important? Because research allows you to have that margin of error. It tells you you are not doing as well as what you want to do, that you need to research this in order to get better. It's a self-audit. So this is our model, and it works. I'm just going to briefly show you, since I started this program in Brampton, these are the patients that have been referred to us as new patients. And you will notice that the majority, more than 765 patients, have actually been referred to us from general internal medicine. Palliative care is not only about patients with cancer. And I will once again ask you to please not call them palliative care patients. They are patients with cancer, they are patients with cardiac failure, with renal failure, with chronic obstructive airways disease, they are patients with a terminal disease. So we are getting patients from all spheres. Understanding, of course, and this brings in, how do we bring it in earlier? How do we start the earlier goals of care discussion? Even having a look at from the ER, where we've had 104 patients referred directly to us, starting the earlier care, advanced care directives. Not necessarily saying that a DNR doesn't mean any treatment. I kind of like the term ANC, allowing natural causes. But of course, explaining to a patient that that means that everything possible that can be done will be done in order to keep them as comfortable as possible for as long as possible. So here are some little graphs which we can show you since we started the palliative care outpatient clinic at the Brampton Civic Hospital as well as the Etobicoke General Hospital. We only got it going in April of last year, but already you can see that we are having more and more patients referred to us. This is on an outpatient basis. We have already admitted 60 patients directly from the community through the outpatient clinic into the ward. They have not gone to wait for a day or two in the ER, where you have 400 to 600 visits a day, where you have people coming from the long-term care facilities that can wait 30 hours there, where you have 300 patients from the long-term care facilities that actually died in the ER while waiting to see a doctor. So seeing them in the community, putting them into the outpatient, and then, if necessary, admitting the patients. Now, you will notice, of course, that the last month or two, we've had a decrease in palliative care clinic visits, and the reason being is we've had more home visits. We're taking the palliative care to the patients where they want it, and wherever we can do it as is best. But it's a dyad. This is teamwork. This is about communication. This is not about the patient belongs to me. And that is where I appeal to you to try and get a funding model that is not fee for service. If you have a funding model that's not fee for service, everybody can be obliged to do education. Everybody can be obliged to do research. But when you've got a fee for service model, it's about how many patients I can collect. So that is the one recommendation that I would say. We move the patients into the community, but of course we change the funding structure of how people are paid. The other program I'd like to speak to you about is the palliative rehabilitation program. So this was a program that was designed and implemented very successfully here in Ottawa at the Elizabeth Brewer and the Ottawa Hospital. The goal of palliative rehabilitation is there to enhance the physical, psychological, social, and professional well-being of the patient, answering the questions that were asked by Mr. Weber about, do we look at the spiritual aspect? Each one of our patients gets a spiritual history. You can have a physical history, how's your pain, how's your nausea, your vomiting, your anxiety and your depression, but your spiritual history. Do you have faith? How important is it to you? Do you have community that you work in? Do you have community support? And how would you like me as your physician or your healthcare provider to provide a spiritual backup for you? So the palliative rehabilitation patients were seen here. And I'm just going to show you, this was an 8-week program. that we had the patient see the OT, the physio, the dietitian, the social worker, the nurse, and the doctor, with the patient and the family at the center of the team. These are values that are taken before the program and 8 weeks later, and you can clearly see the statistical significance of the general activity of the patients that's improved, their mood, their working, their relationships with others, their walking, as well as their enjoyment of life. Validated tests shown statistically significantly. And I have to bring you one of these because this is a patient testimony. And if we're talking about patient-reported outcomes and what it means to the patient and the family, I feel I have been remiss in not writing to you sooner. I cannot say enough about how positive I felt being involved with your team. The thing that impressed me most was your profound respect for me. I think that this was only surpassed by the admiration and respect you had for each other. This allowed me to open up and be more trusting. I knew that anything I shared of value and significance was relayed to other team members, and my wife and I were no longer on our own. None of our patients want to feel helpless, hopeless, and abandoned. That's our job, to take that away from a patient. Simple things seem to take on a profound meaning. You need to eat more, or don't feel guilty about resting. You don't have to endure the pain. That's why we give you medication. Are a few things that come to mind, and as I write, I realize that the most important thing is that we felt we were part of a team, and that made all the difference. And so how do I see the future? I see the future with public health, billboards at the side of the road saying, this is palliative care. It is not a physician-assisted suicide. I also say to you, palliative medicine specialty training needs to be brought to the fore. It's happening. It needs a push. The funding of hospital and community palliative care rehabilitation teams, which is not an expensive funding model, and then, of course, to push the LEAP as well as the Pallium educational sessions and research. I thank you for your attention.
Thank you very much.